a consultant whom I've used numerous times for complicated problems with bone healing, particularly stress fractures in elite athletes. He did his undergraduate work at Johns Hopkins, completed medical school at SUNY, did his residency training in internal medicine at Long Island Jewish Medical Center, and did residency in pathology also at Stanford University. Did fellowships in surgical pathology and nephrology, and it was in the area of nephrology that he became very interested in bone disease, as you might imagine. And so he has served as team physician for the Oakland Athletics for many, many years. He has previously been a team physician for the Golden State Warriors and the Oakland Raiders. And so he is currently the founder and medical director for the Northern California Institute for Bone Health, and we're very happy to have him here along with his wife, Patty.
Without which I couldn't run my practice, so the most important person. Thank you, Tom, very much for this invitation. I'm very excited to be here and present what I hope will be an exciting, stimulating talk to a group of people who may be somewhat unfamiliar with what we do. And so this will be hopefully a lot of new information, and I'm hopeful that what I'm going to talk about will sort of grow in your minds and continue to think about it when you see patients. So we're going to talk about medical considerations as opposed to orthopedic considerations in athletes with stress fractures. So this is F. Clark Miller, who was defensive captain of the 49ers in the 1960s and who kindly gave his name to our stress fracture and fracture healing programs after we treated him for a stress fracture around a periprosthetic left hip replacement. He also had primary hyperparathyroidism, so he had to remove his parathyroid gland. When they did that at Mayo, they put him on a bisphosphonate, which we don't like to treat stress fractures. And so when we got him back, we put him on teriparatide, and that healed the fracture, as it often does and as we're going to talk about. So we have a spectrum of stress fractures, a spectrum of stress injuries. There's no official definition of any of these shin splints, stress reactions, stress fractures. What just happened there? Sorry. Okay. So I use Joe Lane's definition of a partial or complete bone fracture that results from repeated application of a stress lower than the stress required in order to fracture the bone in a single loading. And a stress fracture is usually a focal injury, unlike shin splints, which are more diffuse injury. And stress fractures actually represent a continuum of structural damage to the bone with varying degrees of severity. So this is Frank Thomas. Many of you are aware. Frank allows us to discuss his case in a medical setting. So this was from one of the Chicago newspapers at the time in July 2005, when Frank had failure of his second navicular stress fracture, and basically didn't play much for the last 2 or 3 years of his contract, was let go by the Chicago White Sox and signed one of Billy Beane's favorite low-cost contracts with the A's, and a day later was in our office for further evaluation. So we're going to discuss Frank's case throughout this talk, along with a number of other people. And these are people that I've seen in the last couple of years, some of them referred by Tom and referred by numbers of the foot and ankle specialists around the country. So all of us use our bones all day, every day, stressing them out and creating micro damage which has to heal. And so we have a little bit of basic physiology of bone, and basically down at the bottom, fractures occur when the applied load is increased compared to the bone strength. So what are the determinants of whole bone strength? Whole bone strength is determined by bone mass, geometry, microarchitecture, and characteristics of bone material. And over the last 5 or 10 years, we've had increasing ability to evaluate bone with more tools for non-invasive assessment of bone strength. So we have used this cartoon to discuss either increased bone strength or resistance to fracture since the 2000 NIH Consensus Conference. And so bone strength is equal to bone mineral density, which has been easy to measure for about 30 years, and bone quality, which is made up of a number of factors there like architecture, bone remodeling, damage accumulation, etc. And the search to be able to assess bone quality has been sort of like the holy grail of metabolic bone disease and osteoporosis. And then finally, in October of 2013, the FDA approved new software, which is called Trabecular Bone Score, or TBS, which is software that reanalyzes the DEXA spine image to assess bone quality and microfracture and microarchitecture and fracture risk. So similar to the classification of osteoporosis, as you can see on the left from bone density testing, the trabecular bone score is said to be normal if the number is greater than 1.350. It's said to be degraded, meaning there's poor bone quality, if the number is less than 1.200, and that's a number that I'd like you to remember, and then partially degraded if the number is in the middle. So this is analogous to normal osteopenia, low bone mass, and osteoporosis classification. So these are 2 patients that we have seen in the office, and patient A, you can tell what sport they play, 7 foot, 276 pounds. Okay, African young man from Cameroon. Some of you may know this patient. Okay, both of these individuals, patient A and patient B, had very high bone densities. Okay, is circled on the bottom. You can see the BMD and the Z-scores as we use them, the age-related scores for young individuals. And the player on the left has a trabecular bone score of 1.123. So I told you less than 1.200 is degraded bone. So there's something the matter with this individual's bone quality. Okay, this patient B, who will come back to these cases throughout the talk, was 7 foot 277 and had good trabecular bone score. So this is their graphic. The only database we have approved by the FDA at the moment is Caucasian male and female, but because of the work we do, we have the gender-specific and race-specific databases. So you can see young man A over there in the red area and young man B in the green area for a normal trabecular bone score, and the young man A with a low trabecular bone score. So there's obviously differences in these individuals, and the trabecular bone score or bone quality assay is an independent variable in assessing their bone quality. So this is a little bit of the history of patient A. He had a stress fracture in his senior year in college of L5, and then he had a right navicular stress fracture just after the NBA draft, and had an open reduction internal fixation. Then we saw him in early July, started him on Forteo or teriparatide, our anabolic agent. You can see there his fracture was about 80% healed. Forteo was stopped by the orthopedist in February of 2015. His fracture recurred in June of 2015. He was restarted on Forteo, and he's continued Forteo to this time. He had a low vitamin D level, and we treat lots of these patients with a lot of vitamin D, and you can see the vitamin D story. This is another young individual we're going to talk about, patient C. He was a 22-year-old NBA player. We saw him for his fourth stress reaction, and you can see them listed there, and also his fracture history when he dove for a ball, fractured his left scaphoid, had an open reduction in internal fixation. You can see the vitamin D story there. This young man, as we'll talk about, and many of you may be aware, for the analytics movement in the NBA, many of these players during practice wear devices that record their movement, and so this young man had the highest mileage of any NBA player before he developed this stress. So this is patient C, and this is bone density. And if you look down here at the age-matched Z-score, it's plus 2.7. So his bone density is really high, as is the case with many of these. Okay. So we also on bone density machines have the ability to look at the total body bone mass, both cortical and trabecular bone. And again, this down here in the age-matched Z-score, 2.0, plus 2.0, so total body bone density, very, very high. Okay. Percent body fat over here on the side, 8.7%. Notice down on the bottom, he's classified as overweight. What we need is better databases for use in our athletes. We don't have very good databases, but 8.7%. So this is his trabecular bone score. Very, very low. So again, an independent risk factor for fracture. So when we started to see these trabecular bone scores and numbers of our patients with stress fractures, we went back to retrospectively analyze a group of our patients. And without belaboring it, there were, Without belaboring it, there were many individuals, about 20% of them, that had lowered bone quality or low trabecular bone score. And all of them had high bone density, so the BMD and trabecular bone score were discordant. Okay, there's another device. I don't know if anybody here is familiar with the osteoprobe. This is a device which is being developed by a company, and what it does is it makes an indentation in the anterior surface of the tibia. The deeper the indentation, the, quote, worse the bone quality. So it generates something that's called a BMSI, Bone Material Strength Index. And this has been used in various studies. So here you can see normal individuals in the red and individuals with diabetic bone, which we think has poor bone quality, having greater indentation. And this is a study of a colleague of mine from Norway looking at stress fracture patients, again, having a worse BMSI. So again, another insight into the bone quality of the stress fracture patients. So these are tools that we're beginning to used to evaluate these patients. Everywhere you go, of course, people are arguing about the nature of stress fractures, how they occur, what's going on, etc. You know, I was at the Coliseum a couple of years ago, saw these guys arguing about stress fractures and just helped out the conversation. So one of the things that's important is we always read about military recruits having stress fractures, but it's not clear if the findings from the military recruits, many of whom are undertrained, can apply to our elite athletes, many of whom are overtrained or well-trained, et cetera, et cetera. So they may be different populations, and we need to look at different factors about them. How many stress fractures are there? Nobody actually knows. But in this analysis of runners, if you fit this definition of running 100 times a year, there were estimated to be 462,000 stress fractures, and that is only a portion of the athletic population and the non-athletic population. So probably double that number at least. So classically, we've always talked about fatigue fractures as excessive repetitive stress on normal bone and insufficiency fractures as normal stress on weakened bone. We've never really had a good definition of what is fatigue. But maybe with the analytics movement, and I'll show you at the end, maybe we're going to get to a better definition of what fatigue is. So what is the pathophysiology of stress fractures? Well, in the early 2000s, we went through this type of evaluation. Point 4, lack of adequate rest may increase osteoclast activity. I'm going to show you how that has come to be an important feature of what's going on. And at that time, it was thought the final common pathway may be tissue ischemia induced by tissue injury, but there was nothing more precise. This actually is my favorite paper in the entire stress fracture literature, and if you haven't read it, I suggest you read it. How stress fracture incidence was lowered in the Israeli army, a 25-year struggle. So just as an aside, in the United States and in other Western countries, we know that about 10 to 20% of any military recruitment class is going to develop stress fractures. In the United States, we flunked them out, and we're left with military recruits that can go forward. So we accept 20% more than we're going to need, knowing 20% will flunk out. Well, in Israel, they need 100% of their population to be available for military service, and so they've spent all this time and money trying to evaluate stress fractures. And in this, they were looking at their basic and human research, and including the implantation of strain gauges in the legs of elite military police. Very interesting. And they concluded from all of their work that the stress fractures were mediated by bone remodeling issues, and we'll come back to that, of course. So this is a bone problem, and we need to look at the bone cells. So classically, we've known about osteoclasts and osteoblasts for 50 years. But in the last 10 to 15 years, there's been a lot of work on osteocytes. And so what are osteocytes? Osteocytes are like old osteoblasts that get incorporated in the bone matrix and are now known to be the master cells of the bone. So this is a picture of osteocytes, and they have canalicular pathways that run to all of the other bone cells to, in some way, influence all the other bone cells to do their various jobs. And it's through canalicular pathways, as on the right, that these cells are the mechanosensors of bone. And there's fluid in those canalicular pathways. The fluid goes up and down and transmits the messages. So micro damage, which is the basic problem in stress fractures, disrupts the canalicular flow and kills osteocytes. So looking now at where stress fractures may be, I think that certainly they may be part and parcel of a disordered, dysfunctional, or diseased osteocyte system where fluid mechanics, shear strain forces, mechanosensory forces, all of these things that we've known about result in abnormal bone remodeling. So we'll see where that's going. So we have evaluation of the patient. So when we see the stress fracture patient, we're looking at all of these issues to try to define what's happened to them. And it probably takes me an hour and 15 minutes to take a history from one of these patients, to go through all of these factors, some of which are important in individual patients, some of which aren't. And we were talking about one of Tom's patients, a very big gentleman, whom we'll see in a couple of slides, and nutrition factors. So what I'm always saying to these guys is, just because they're 6'5", 250 pounds, does not mean they had good childhood nutrition. And always something to, and most of the time, not very good adult nutrition, because if you ever take a history from them, you know, I hate to say it, they're making several $1 million and they're stopping at Denny's on the way to the ballpark, or In-N-Out Burger, one of the favorites for the A's. So it's always a question of what is going on with their nutrition. Anyway, we have lots of things. You're also aware of the imaging. So we use bone density testing a lot, as you saw, to try to differentiate fatigue fractures from those individuals with insufficiency fractures. And we know that there's an important influence of race on bone mineral density, and that blacks have higher bone densities than whites for a variety of reasons. Sometimes it's denser, sometimes their bones are bigger. So this picture of Bill Lambier and Muggsy Bogues. Bill was 7 foot. Muggsy was the shortest guy ever to play in the NBA at 5'4". And I always say, who do you think had denser bones? Probably Muggsy Bogues. So neither one had bone density testing that I'm aware of. Okay. And from the medical point of view, whenever we look at these patients, we're thinking about, can there be something else going on in their body that is affecting their bone? So in the osteoporosis and metabolic bone disease world, we're always looking at so-called secondary causes of low bone mass. And probably the most important thing in all of these athletes is vitamin D insufficiency and deficiency. So unfortunately, there's no study that looks at the secondary causes of metabolic bone disease in any population of stress fracture patients, something that a nice fellow could review my charts and we'd have the paper. So when we see the patients, we're getting a whole bunch of lab tests. And so the patients show up at 8 o'clock fasting in our office, and Patty draws their blood because we don't trust them to the lab. And these are all biochemical risk factors for fracture that are independent from bone density, independent from TBS. But most of these are risk factors in older adults and postmenopausal women with osteoporosis, and we're not sure of their role in stress fracture patients, but we get them and we're looking at them and we have data to look at them. And most of the time, you know, in the anorectic runners, we're looking at the estradiol levels, et cetera, et cetera. But we've had numbers of patients that have had turned out to have Marfan syndrome, turned out to have osteogenesis imperfecta as underlying bone disease in these patients. So we do this whole big workup. And one of the important things that we can do now is to assess their bone turnover. So bone turnover is the interrelationship of the bone building cells, the osteoblasts, and the bone remodeling cells or resorptive cells, osteoclasts. And you have a physiologic range of bone turnover, and then you have patients that have too much bone turnover or too little bone turnover. And nowadays, we have the ability through biochemical tests to measure what's happening in bone formation and what's happening in bone resorption. So we use the yellow markers, the markers whose names are printed in yellow here, highlighted, to measure. So we're measuring 3 bone formation markers and 2 bone resorption markers in all of our patients. And then we use that, as we'll see, to follow their response to various treatments. Are they getting more bone formation? Are they getting too much bone resorption? What's going on? Are they actually compliant with their treatment, because we know what the responses to these medicines should be. So these are a couple of individuals you're familiar with that have had multiple fractures and questions of stress fractures or underlying metabolic bone disease, and none of these gentlemen have ever been fully evaluated that I know about. So this is from an article by Kading, who has written a lot about stress fractures, and I'm not going to go through this management tree other than I have some circled boxes at the bottom, which is the end of the treatment usually for orthopedics. And that is failed surgical treatment or the fracture's not healed. And is that going to be the end of the story? We're going to let these individuals go with fractures not healed and or surgical treatment that hasn't worked? So we need to see what's going on. So let's come back to patient B, who had high bone quality and high bone density, was 7 foot 277. So we saw him in May of 2015. The last time his foot was well was 2011. His foot, and you can see the history here. The foot became sore, stress fracture, played a couple of games, open reduction, played a couple more games, imaging not healed, played in 2012, 2013, foot was pain-free. At the end of the season, the X-ray showed screw was bent, so a bigger screw was placed. There was still a, quote, tiny line. The next season, he played about 20 games out of 82, foot still not perfect. Played 2014, 2015 season, routine X-ray, still a line. So these are his X-rays. When we saw him, they'd been obtained a couple of weeks before, and he'd been referred. So I don't think anybody in this room can fail to see that the 5th metatarsal stress fracture, which at this point had been a non-union for 4 years. Okay, and he had had, at one point over here on the right, he had had an osteotomy of the first metatarsal to try to take some pressure off of the 5th metatarsal. So we'll show his course later in the talk. So we've had these approaches to the management of stress fractures. What I call the classical non-medical approach, what you're all used to, orthopedic approach, physical therapy, non and partial weight bearing, maybe bone stimulation devices, shockwave lithotripsy, surgery, other techniques. What I'm proposing is that we need a new medical approach to work in conjunction with the surgical approach, calcium, vitamin D, teriparatide, Forteo, which is our only anabolic drug at the moment, a question of bisphosphonates, I'm not in favor of them, other medications and treatments that we can begin to use, mesenchymal stem cells, and newer anabolic agents, romosozumab and abaloparatide, both of which we think are going to be approved for treatment in 2017. So we're going to have a lot more information. So calcium and vitamin D, this was a prospective study of female Navy recruits. Half were given calcium and vitamin D, half were given placebo, and there was a 20% reduction in stress fractures just from starting these individuals on treatment. This was a prospective trial. Okay, so question, should we be starting our athletes on calcium and vitamin D before the season starts? Okay, this is some data that I've collected along with Mike Schindel at the New York Football Giants. So the Golden State Warriors, over a couple of years, 9 to 12 of 16 individuals were deficient or insufficient in vitamin D. The New York Football Giants, Mike studied in 2010, 80% were low. The Oakland A's in 2011, 90% were low. We know vitamin D supplementation in the elderly will improve muscular, neurologic, and bone status, prevent falls, improve coordination, prevent fractures, but we have no real data on our athletes. Okay, this is Finnish military recruits. Again, those with stress fractures tended to have lower vitamin D levels than those without stress fractures. So what do we know about athletic performance and vitamin D? Actually, not much. This is an area ripe for a young fellow to really take on and do some work. But in this 2009 meta-analysis, it was felt that peak athletic performance could occur when the 25 vitamin D level is at least 50 nanogram per ml. This is usually 2 to 3 times what we see when we get baseline vitamin D in the athletes with stress fractures. Okay, so the Stanley Cup. What do we know about the Stanley Cup? Okay, so the Chicago Blackhawks in 2006 became the first, quote, vitamin D team in history. Their trainers set up for them to start taking 5,000 IU of vitamin D the first day of training camp, and they took it every day for the entire season. They won the Stanley Cup that year, and they've won it several times since. Cause and effect or not? The trainers in very soft data felt there were fewer injuries, fewer fractures, et cetera, but this has not been published, so it's all anecdotal. So we look at ways to accelerate bone healing in our athletes, and we primarily use the Exogen bone healing system, now moved from Smith & Nephew to Bioventus. This is, as most of you are aware, a 20-minute treatment, and it's, again, for skeletally mature adults. Okay, so we can't use it in children with open epiphyses. And it's been used and approved for distal radius fractures and tibial diaphyseal fractures, but we use it all over the body, as you may do. So then we come to teriparatide. So teriparatide at the moment is the one drug we have that builds bone. And it works by increasing trabecular bone volume, increasing trabecular bone conductivity, increasing cortical bone thickness, and shifting trabeculi to a more plate-like structure. So this is the very iconic photograph that we use showing an individual at the start of a Forteo trial on the left and a repeat iliac crest bone biopsy 21 months later showing all of the features of increased bone mass. But Forteo comes with a boxed warning because of malignant bone tumors, osteosarcomas, that were produced in rats during the preclinical trial. There's a lot of information about this. And because of this, we're not to use it in individuals who have increased baseline level of osteosarcoma, including Paget's disease of bone, unexplained elevations of alkaline phosphatase, open epiphyses, single most important factor for this group, and prior radiation therapy. So these are really warnings. They're not contraindications, but again, we have to be careful. Pediatric populations with open epiphyses and metabolic bone diseases other than osteoporosis. So this was a case that one of the Warriors trainers pulled out of one of their meetings for me. This was a 17-year-old college football player, had a scaphoid fracture, and was given a 28-day course of Forteo, which they alleged healed his non-union of his scaphoid. But we would have been very concerned about the age of this individual, and so we would have gotten, of course, skeletal bone age assessment for these individuals. And we've had cases where we have minor league pitcher, left elbow stress fracture. He was referred to us because they wanted us to give him Forteo. His bone age was 17.6 with open epiphyses, so Forteo was contraindicated. He just had to rest for 9 months to get his fracture healed. So as the assistant GM cleverly asked, because lots of players lie about their age when they're coming from certain parts of the world, asked if this could be used to assess the age of players, and of course it can. So, what did I do here? Okay, so we've now had, Forteo was approved in 2002. So we've actually had now at this point 14 years of experience. And this paper, 10 years of safety, now probably more than 3 million people have used Forteo. And there were 3 cases of osteosarcoma. I discussed this with Tom last night. They've been adjudicated by the FDA, and none of them have been felt to be due to teriparatide. There's also a post-marketing surveillance study that's ongoing where they went into a large number of tumor boards around the world, looking at all the cases of osteosarcoma. After 7 years of study, no cases of osteosarcoma related to teriparatide. We discussed this with all the athletes. No athlete has ever refused to take teriparatide because of this boxed warning. Okay, so those were for approved indications for teriparatide. Now we're moving to the off-label use of teriparatide. So why should we use it for fracture healing? Well, it's anabolic for osteoporosis. It stimulates mesenchymal stem cells. It stimulates VEGF. It works through signals similar to PGE2, and it may have an effect on the osteocytes, which may be part of the pathogenesis of stress fractures. So way back at the beginning, there were at least 15 non-clinical rat, beagle dog, etc. studies on the use of teriparatide in healing fractures. So on the bottom is example 5 and 10-day treatment of experimental animals with teriparatide, PTH, on the bottom, and you can see that there is a marked increase in callus formation from teriparatide use in experimental animals. Oh, I keep pressing the wrong button, sorry. So human studies in fracture healing. And again, just to emphasize that fracture healing is off-label, we have to discuss it. So it turns out we were the first ones to report the use of teriparatide in human fracture healing. And these were some of our players that we had seen. This was for discussion for physicians, Major League Baseball physicians meeting in 2010. So I was saying that the first player that we actually treated in 2004 was an individual got hit by a pitch, fractured a metacarpal. Orthopedist said to me, it's going to take 6 to 8 weeks to heal. We treated him with teriparatide. His fracture was healed in 3 weeks. And he said, oh my goodness, maybe we've got something here. So then we've treated numbers of baseball players, football players, basketball players, et cetera, et cetera. So we've had probably more than 400 cases in our practice used in off-label indications for acute fractures, stress fractures, non-union, and in our practice, which Patty hates, our little country practice in Orinda, California, 2,200 cases of Forteo being used for FDA-approved indications. So we have some data on fracture healing in humans. Okay, this is a study that was done by Lilly using distal radius fractures, and patients got either placebo, 20 micrograms of Forteo, which is the standard dose, or 40 micrograms of Forteo, which they thought was what was going to be required to heal fractures, and they started within 10 days of fracture. And time to healing was assessed, and basically what it turned out was that the 20 microgram dose actually healed fractures faster than the 40 microgram dose, and that it was a significant improvement in fracture healing. But because the paper hypothesized that 40 micrograms was going to be the fracture healing dose, this paper was doomed a failure because the 20 microgram dose proved to be more effective than the 40 microgram dose for reasons not totally understood. But anyway, there is human data. So when we use Forteo in this graphic developed by Dr. Bilzekian at Columbia, when we use Forteo as an anabolic agent, there is an immediate increase in bone formation. I mean, like from the first injection. Okay, it's not like you have to wait 18 months for some hypertensive or cholesterol pill to start working. Starts working with the first injection. So there's a marked increase in bone formation. Then, because bone resorption and bone formation are coupled metabolically, there subsequently is an increase in bone resorption markers. But we have defined this black area as the area where bone building takes place. And so Dr. Bilzekian has called this the anabolic window. And different patients have different anabolic windows. So we use those bone turnover markers of the bone formation and the bone resorption to help us define what the extent of the anabolic window is. So we see these patients have their P1NP go up and up and up, and then it starts to come down a little bit. We see the bone resorption markers, particularly the serum C-telopeptide, start to go up, and sort of somewhere out around 12 months, 18 months, 24 months, they sort of cross, and it's sort of the end of the anabolic effect of teriparatide. So there's another study of parathyroid hormone 1 to 84 that was done in Europe using pelvic fractures and showing again that parathyroid hormone, this time in the 100 microgram dose, helped to heal pelvic fractures. So we have data, and we have a lot of increasing anecdotal data with the use of teriparatide in patients who are having atypical femoral shaft fractures, perhaps from bisphosphonates. So let's come back to Frank. Okay, so he had 2 navicular fractures that were operated on. This is a little synopsis. So his first navicular stress fracture occurred in July of 2003, open reduction 2004. Second navicular stress fracture 2005, open reduction 2005. And when we saw him, there were non-union of both fractures with 1 centimeter gap. He was started on Forteo and a bone growth stimulator on January 27th of 06, and his fractures were healed 6 months later, 5 months later. So he then went on to finish a Hall of Fame career. And when we were doing our retrospective study of the trabecular bone score of the athletes, here was his trabecular bone score. So again, not known at the time by the surgeons, not known at the time by me when we were treating him, but again, something the matter with his bones. What exactly we don't know, but probably contributing either to the causation of the stress fractures or to the lack of healing of his stress fractures. Okay, so now we've come back to patient B, who I showed you the previous x-rays, and he had 4 years of a non-union of a fifth metatarsal fracture. So this is his x-ray. He was on Forteo and a bone growth stimulator for about 15 months to heal that 4-year-old non-union. So in the old days, there was no hope for any of these patients. They developed a non-union and it never went anywhere. 20 years later, they still had a non-union and they were shuffling around. So this, again, CT scan in August. Okay, so now we're very excited because we have new, maybe even stronger drugs coming along. So this is abaloparatide, which its fracture article was just in JAMA last week. And it's suggested from the bone density data that this drug may be 40% stronger than teriparatide. So it's going to, again, be daily injection, 1 injection a day, subcutaneous, given by the patient. The other medicine that's coming along is romosozumab, and this, again, in its early clinical data, looked like it was stronger than teriparatide also. So we're going to have 2 new anabolic drugs. Both of these studies are for fracture prevention and osteoporosis. We're not sure of the fracture healing capabilities of either of these drugs, but we're likely to start using them because of the fact that they are alleged to be stronger than teriparatide. And bisphosphonates, as I've mentioned throughout the talk, I'm not a big bisphosphonate fan for stress fractures. In the Israeli studies, bisphosphonates could not prevent stress fractures from occurring, and I don't think they help the healing of stress fractures. So I wouldn't use them. So again, from my favorite paper, what happened over the about 20-year period of time, they reduced their stress fracture incidence from about 30% to 11%. If you look down at the bottom of the chart, they felt that they had changed the grade from more severe grade 3, grade 4 fractures and more grade 1 to 2 fractures. So that was an important thing. How did they do this? Okay, they were not using teriparatide. They were not using bone growth stimulators. They were barely operating on these individuals. So what did they find out? The reduction was achieved by modified training program with reduced cumulative marching and an enforced sleep regimen. So they did a number of studies where soldiers were in the erect posture for 60, 70 hours and looked at their bone remodeling. They found that they did much better if they were in a horizontal position. And, you know, I always talk about this as far as circadian rhythm. Now we know regulates bone resorption, and there's more bone remodeling at night than there is during the daytime. And this has been recognized for many, many years, because I always tell the story about Casey Stengel, the manager of the Yankees in the late 1940s and early 1950s. And when he was asked about the players having sex before a game, he said, it's not the sex before a game that bothers him, it's the staying up all night looking for it. So the role of sleep deprivation in fractures was recognized even by Casey Stengel many years ago. I wish I had a Yogi Berra story to go there, but I don't. So coming back to the fatigue fracture versus the insufficiency fracture, the insufficiency fracture, low bone density, maybe abnormal trabecular bone score, the fatigue fracture, where are we getting there? So as I mentioned, as part of the analytics movement in the NBA, the players' movement is tracked quite closely now, and many of them wear these sensors in practice, not approved for games yet. In the games, they have sport view cameras that are above the courts tracking every movement, but in practice, they wear these devices that contain 3D accelerometers, 3D magnetometers, 3D gyroscopes, and GPS tracking, et cetera, and real time, they're projecting to the trainers what's going on with each individual athlete. And I don't have time to really discuss this more other than that these have led to major changes in the training regimen. And they're now, the first person that the Warriors hired when Steve Kerr became the coach was a sleep expert. So the Warriors have totally changed their travel plans. In the old days, the teams used to leave the game city at night, 2 in the morning, 3 in the morning, etc. Very commonly now, the Warriors sleep overnight in the city they were in and fly in the morning the next day, in attempts to get at all of this sleep, bone resorption, better awareness, better sleep quality, less fatigue, maybe better player movement. So to conclude, stress fractures are not traumatic fractures and cannot be treated like traumatic fractures, although unfortunately that's the way they usually have been treated in the past. We need to evaluate the so-called intrinsic and extrinsic risk factors more thoroughly in the players in hopes of getting to greater areas of pathogenesis and prevention of injuries. How much do stress fractures cost society? Nobody knows. This was from the female Navy recruit study where they gave calcium and vitamin D. So this was one naval training base. And they estimated that over the course of 1 year, there were $26 million in expenses for that one naval recruiting course that, for sailors who were lost to the military. Secondary causes of bone disease are usually not considered. We give a lot of calcium and vitamin D, and presently available and future anabolic agents should be considered. Tom and I were talking last night about, we know fifth metatarsal fractures are hard to heal. They take a long time, whatever the estimate is, 12 to 16 weeks or 16 to 18 weeks. We know there's going to be a high incidence of delayed union, non-union. Should we be treating those patients from the time the fracture becomes apparent with an anabolic agent and a bone growth stimulator? That's not typically the standard of care, but maybe we need to move toward that. And I would say, unless somebody points it out to me, that I don't know of a randomized control trial of pinning the fracture versus letting the fracture heal medically, or now versus a medical treatment. We've always done pinning the fractures, but my small niche of practice is to see people who have actually failed the first, second, third orthopedic procedure. So I don't actually know what the recovery is of patients. Then for those of the physical therapists here, I would say that most of the patients are advanced too quickly and return to activity too early. Not only because we want to, but because they want to. And we very frequently have patients that are going back to their return to play with maybe still a little bit of a fracture that's unhealed, et cetera, et cetera. What to do about that, I'm not sure. Over the next 10 to 20 years, the development of newer anabolic agents may make the approach to treatment of stress fractures radically different than it is today. So thank you very much. And if there are any questions, I'll be happy to try to answer them. Yes.
So as part of our referral practice here, we have patients that are at risk for healing because they've had multiple surgeries. I've tried to use Forteo a few times and had the insurance companies not approve it. What's the way that you get it approved, and what's the argument we can have to try to utilize it more?
Okay. So Patty has her ways of doing things, as you might imagine, and so we use terms like the patient needs an anabolic agent, an anti-resorptive agent is contraindicated, et cetera, et cetera. As we said, fracture healing is off-label. We've been fortunate, and we have a high usage of samples, but it is a problem. And probably the companies are not going after an indication for fracture healing. They know fracture healing is done worldwide off-label, so why should they spend $500 million to get an indication? So it is a problem, I agree. But if you use the terms, the patient has underlying bone disease, you don't have to be more specific, underlying bone disease, and their condition requires an anabolic agent. The only anabolic agent we have is teriparatide, so you may have some luck there. Yes, sir.
With regards to the vitamin D supplementation, is it the vitamin D3 that you use or something different?
So, no. So there is vitamin D2, which is plant vitamin D, and there is vitamin D3, which is animal vitamin D. And the only real difference clinically is that vitamin D3 is about 40% more effective than vitamin D2. So you would have to give a bigger dose of vitamin D2. Vitamin D2 in the United States usually comes in 50,000 unit pills, and vitamin D3 comes in 1,000, 2,000, 5,000 pills, 10,000, and even now 50,000 pills. So without discussing brand names, we use a drug called Replesta, which is 50,000 units of vitamin D3. And when you write a prescription, it's actually over the counter, but we write prescriptions for the patients, check do not substitute, because otherwise the pharmacist is going to substitute generic vitamin D2 for the vitamin D3. Okay? And one of the things I should say is, since so many of the elite athletes have low vitamin D levels when we see them, and that's a whole other discussion, but we just give them a handful of vitamin D pills as they're leaving the office, Replesta samples, and tell them to take one a day for 5-6 days, and by then we have the vitamin D level back, and we tell them what's going on, and we usually then give them the vitamin D 50,000 units for once a week, or if they're really low, twice a week for a month or two, and then take them, eventually tapering them to about twice a month of the vitamin D3. Yes, sir.
Thanks for the wonderful overview. One of the things we looked at in the military was elemental calcium versus different variations of calcium. You had recommendations. One of the things we found was calcium citrate, and others higher bioavailability due to intestinal issues, etc. Do you have recommendations on that?
Yeah, so we use calcium citrate in all our patients, okay, when we can get them there. And we're usually getting, even in these athletes, about 75% of them, we have them collect a 24-hour urine for urinary calcium and creatinine clearance. And then if the urinary calcium is low, we make sure they're taking calcium. If the urinary calcium is normal, we tell them just continue whatever their diet was. And usually we're giving about 2 calcium citrate 500 milligram tablets a day. Yes, sir.
A couple of questions. I really like your talk
One of the things we're observing in shoulders is rotator cuff tears are associated with vitamin D deficiency too. So I just wonder if you could comment on tendon tears and whether that, you've noticed that.
Unfortunately, I know nothing about that. But I will look into it. But I've not heard that discussed in the medical areas at all. But, I mean, there are now some very large clinical trials of vitamin D. I'm talking about 50,000 patients being done. I'm not sure that looking at tendon injuries is one of the areas they're looking at, but we could certainly interest them in maybe doing something like that. How vitamin D actually works is very complex, and the tendons and ligaments are mostly avascular. I mean, not much vascularity. So I don't know how vitamin D would play a role there. But I'd be interested in your sending me a reference, and I will ask the world's experts and get back to you.
My second question is that there's been a trend in people's diets, sort of vegan diets or other diets that, and some of the athletes now are going on these diets as well. I'm just wondering how do those diets affect their bone health?
Okay, so protein is probably important for bone health and adequate nutrition and athletic activities, and except in like athletes from the subcontinent of India, where they seem to do okay. I don't think we have much data. The A's have gone through various evolutions of sports nutritionists with the players over the last 5 to 10 years. And now our sports nutritionist has everybody on sort of a higher protein, lower carb diet, as opposed to any type of vegetarian diet. All of the teams have approved vitamin formulations that they put out. The A's put out 5,000 unit vitamin D pills for players to take when they want to. Some do, some don't. So, but the role of nutrition is very difficult to look at because in most of the nutritional studies, it's hard enough to study one item like calcium, for example, or magnesium. And people always say, oh, you got to take magnesium with the calcium. Actually, nobody knows. And so to get a whole look at diet is unclear. Meanwhile, about earlier this year, there was an article of analysis from the Women's Health Initiative, which was a study done in the early 2000s, looking at those individuals who ate a Mediterranean diet. And there was supposed to be decreased fractures, especially hip fractures, in the women eating a Mediterranean diet. So that's all I can say about diet. I can't say anything about vegan, vegetarian, etc. Yes?
You talked about metabolic bone disease studies in the military. We looked at a metabolic bone study with femoral neck stress fractures. And so we basically sampled the iliac crest with femoral neck stress fractures and without. We couldn't find any metabolic parameters differences. We sent it to the FIP, Porcelain Institute of Pathology, looked at all kinds of things. But we did find a lower bone density and also some calcium metabolic issues, including creatinine clearances, things you talked about. Comments on that,
Yeah, so
or where
the
we could go, because you talked about studies, but where we could go with those studies in the
is
future.
that the anterior iliac crest, where metabolic bone biopsies are usually done, is a non-weight-bearing site. And whether that has any relationship to what's going on in the weight-bearing sites is unclear. So there's, again, one of my favorite studies, which is by a guy by the name of Pathophysiology, is I think the way you pronounce his name, which was a peculiar circumstance case report where an individual was participating in a clinical trial was labeled for a bone biopsy, was then hit by a truck, and was autopsied. They took bone from 25 different sites around the body. And they were all tetracycline labeled because the patient, so they took iliac crest, they took lumbar spine, thoracic spine, humerus, et cetera, and the bone turnover in most of the sites is different from the iliac crest, and I can send you this article, so that the iliac crest has been used standardly for all these studies, but it may not reflect what is going on in the rest of the body. So all the stress fractures are occurring in sites that are weight-bearing in some way, or that are getting overused, like the arms in archery, javelin throw, whatever else. So, yeah. Tom.
All right, great talk, thank you. That's definitely an area where we all need to learn a little bit more. I certainly learned a lot when I had a tall basketball player who was having stress fractures, and actually he came to the United States. When he was signed, he already had stress fractures, and so it was a constant battle with him because his initial level was below 20, and so we had to pump him with vitamin D, and he was very resistant to that, and we ended up having to have him come in for scheduled injections in order to get his level up.
Well, let me just make a comment there. The 25 vitamin D level, 25 hydroxy vitamin D level, is a measure of your total body stores, okay? So the total body stores of someone who's 7'6", 320 pounds or so, is going to be much greater than the total body stores of someone like myself. So you're going to really have to load up that individual to bring up their vitamin D level to what we would consider a normal level. That's what happened in a lot of these basketball players. We were using doses of vitamin D that nobody would actually prescribe in clinical practice. You know, yeah.
And I appreciate all the help you've given me over the years with some of these stress fracture athletes.
You're very welcome. It's my pleasure. It's my pleasure to have been here. Thank you very much for the opportunity.